This program has been brought to you by Blue Sky Bio. We're not just compatible, we're better. We're a mountless design, easy to insert, with a blasted surface, a 1.8 millimeter collar, compatible with Straumann ITI implants, as well as LifeCore single-stage implants. Blue Sky Bio implants are easy to use, easy to insert. We're not just compatible, we're better. This patient has been missing his tooth for a while. There's adequate room to place an implant, but the mesiodistally you can see the width. But buccolingually, it's got an indentation. There seems to be quite a bit of bone missing, both buccal and palatal here. You can see that the tissue depth is several millimeters on the palate. The tissue depth on the buccal is also several millimeters deep. This is a bone sounding tool that will give us an exact measurement of the buccal lingual thickness, and it's only about 3 or 4 millimeters thick at its thickest point. We're going to try today to place a full thickness 4.1 millimeter implant. We're going to take a crestal incision. We don't want to do full flaps when we're doing a ridge split or an immediate osseous distraction because we will not have enough blood supply. So here we are with our incision, and we're not going to reflect it all the way. We're going to do a partial thickness dissection on the buccal and continue doing that. We're going to do a partial thickness dissection also on the lingual when we get to it right now, so that we again leave some tissue over the bone for a blood supply. It's important that again no full thickness flaps are elevated. After this phase, we're going to just elevate a little bit so we can see just the crest. Then we're going to use a very small thin fissure burr to create a slot, S-L-O-T. And this slot is going to be utilized to help divide the ridge. Again, at high speed, just a little bit, light pressure. We're not using this for our osteotomy, and with light pressure, we're not going to get any loss of crest. I'm using the same scalpel and rocking it mesially distally to introduce it as deep as I can using a scalpel. Then I'm going to use a handmade osteotome that is really a ridge splitter and introduce it by hand, rocking it back and forth to begin the split. Then I'm going to use a point-driven instrument rotation to try to get it in line to the exact spot. Then I'm going to put a direction indicator and taking an x-ray. I've got to change the direction. Again, I'm not using an osteotomy here with a drill. I am just using a very sharp handmade pointy instrument as a pointy osteotome, tapping it into place, changing the angulation a bit. And now what I'm doing is I'm just creating an osteotomy into the hole, into that section, down to about 2 millimeters. Of width. Once I have it in the direction I want to go in, I can then begin using a special set of screws that are flared to become wider at the occlusal. This one is 2 millimeters in depth. To begin pushing aside the bone, mostly on the buccal, to begin ridge expansion with increasing sizes. Once I've got it in all the way, again, this is not an implant. This is a special custom screw that is being introduced to flare out the buccal bone. That one was about 2 millimeters in diameter at the 2.8 millimeters. This is closer to 3 millimeters at the occlusal. Again, slowly introducing it, backing it out, reintroducing it again to try to get expansion of the bone without utilizing a hammer strike, which would have an uncontrolled fracture. Now I'm using a twist drill, now that I've been able to expand it, to try to find depth to full depth. Now you'll see that I'm coming out towards the buccal. There's really an undercut as you go occlusal, and if I would go straight up and down, I would perforate that region. I am going to go on angle on purpose. Again, the osteotomy was done a little deeper. Now I'm taking the ridge expansion tool in a bit deeper. Now I'm going to introduce my implant. again, it's being introduced towards the buccal cusps. I know I'm going to be using an angled abutment. Now I've introduced the implant, and as you can see, I put it's a mountless device. I put in our hand mount, checked it at 30 Newton centimeters. Here's the abutment in place, because now I know because it could withstand 30 Newton centimeters. So as you can see, the abutment's in place at over 30 Newton centimeters and prepared. It's an abutment that's made for an angle, and you can see now the temporary is in place, looking very nice, and it's out of occlusion, so you have a no-load temporary. Patient's very